We are about to get started today. We are at breaking down barriers, addressing the coverage needs of communities of focus. My name is Jennifer Cardenas. I will be facilitating this conversation. My pronouns are she, ella, and I am the outreach coordinator of Young Invincibles from the West region here at YI. And to get started, we will allow the panelists to introduce themselves. And whenever y'all want to start.
I guess, would you like me to get started? Okay, awesome. My name is Sharon Crook. I am the executive director of the Coalition. We are a substance abuse prevention organization in Lufkin, Texas, which is deep East Texas. We like to joke that we are behind the pine curtain. We're about 2 hours north of Houston and only about an hour away from 45 minutes away from the Louisiana border. So deep East Texas. And I do work in the area of substance abuse prevention, but I also do work in the area of poverty alleviation. So happy to be here.
Thank you.
Yes, good afternoon or good morning, depending on where you're attending from. My name is Carl Cooper. I'm the Director of Public Health Programs at the American Association on Health and Disability. We are a national cross-disability organization working to promote health and wellness for people with disabilities, regardless of what type of disability. So whether it's physical, intellectual, developmental, or sensory disabilities, we work to promote health for those individuals. And I have been actually at AHD for 9 years as of next month, because I started right as open enrollment 1 started in the fall of 2013 is when I started there, when we started a project where we're doing technical assistance to health insurance navigators on disability issues. So I'm very happy to be here today.
And then, hello, my name is Angela. My pronouns are she, her, hers. And I work with Borrego Health in California as an HIV health educator and a PrEP navigator. So for those of you, since we have folks from all over that aren't familiar, Borrego Health services Riverside and San Diego counties in California. And we primarily focus on the Inland Empire region. And so providing access to care in areas where especially there's not a lot of access. And so I work with populations providing HIV prevention, testing, and access to PrEP and PEP services.
Thank you, everyone. It's amazing to hear the work that you're doing. And, this is why we're here today. So while all communities benefit from outreach education and enrollment assistance, some experience additional barriers. That's what we're talking about today. So one thing I do want to remind the audience is that if you do have questions, there is a Q&A box right at the bottom of your Zoom. And feel free to use the chat as well. And let's do a quick pause. Shelby, it's not a Zoom event unless we have just a tiny little glitch, but everything's on track. Shelby, can you please introduce yourself before we get started? Thank you.
Sure. Thank you so much for having me and for your patience, as I am apparently new at Zoom, right? After 2.5 years. I'm Shelby Gonzalez, and I work for the Center on Budget and Policy Priorities. I lead our immigration team, where we really focus on the intersection of immigration policies as policies intersect with people with policies that impact people with low and moderate incomes. But I come from a long history of working on health coverage issues. So I know many of you. I've had the privilege of working with so many of you, and I'm so glad to be here today. Thank you.
Thank you. Thank you for that. And the reality is, you know what? Zoom is, it changes, so don't feel bad. We made mistakes. That's why I think I logged in like 20 minutes early just in case. So no problem with that. So let's get started. Now that we know where we're located, I do want to ask some of the questions. Give me a second. See, even I'm having a little technical difficulties. So when we talk about the characteristics of the community, can we describe the health and disparities faced by these communities? So feel free to add to anybody answer this question. What are the unique barriers this community faces when accessing healthcare?
I don't know if you have a specific order that we want to go in, but as I said in my introduction, I am in Deep East Texas, which is a very rural area of the state. So that's kind of the population that I am here representing are rural folks. The specific health disparities faced by our communities out here, we are higher than the state average in smoking rates, obesity rates, children in poverty. If you look at the Robert Woods Johnson's county health rankings, the counties, the rural counties in my area are consistently at the bottom of the rankings. And so those are just a few of the health disparities that are faced by rural folks for the most part. And I think really unique barriers that folks that live in rural areas face. What we hear anyways is transportation. That's always one of the things that floats up to the top. And then I would say the second thing is no insurance or underinsured. And then something that's been more recent, I think, with us moving this 2.5 years through the pandemic, in our rural area at least, there's more distrust of public health voices, and that's something that we hadn't seen before, but unfortunately we're seeing that now. So that's a barrier that we're having to face and overcome. And I should note, when I'm talking about rural folks, I'm speaking from my personal experience. So I certainly don't want to stereotype or make anyone feel like I'm voicing for them. I'm just talking about my perspective and what I've experienced. So.
Thank you. And let me, I'm gonna see, Diana Douglas, you had a question. Was this for Sharon? Is this a question specifically for Sharon? Can you add that? Just so that we can, like, if it's directed towards her, then I can have her answer that question. When she answers, we'll get back to that. Would anybody else like to answer the question?
Sure. Yeah, I can talk about the disability population. There are some significant health disparities when you're talking about the disability population. They're 30% more likely to be obese. They're 60% more likely to smoke. They're 2.5 times more likely to develop diabetes. They're about 3 times more likely to have cardiovascular disease. They're twice as likely to not see a doctor due to cost. Women with disabilities are less likely to have current mammograms or Pap tests. So you can see there's a lot of different factors that come in, and there's different reasons for all of those different statistics, but it does show that there is a definite disparity when you're talking about health related to people with disabilities. And lots of times it's not necessarily related to the disability itself. It's just related to other situations that go along with that. For instance, the fact that they're more likely to not see a doctor due to cost. It's probably related to the fact that employment rates are lower among people with disabilities, and therefore there's socioeconomic stresses that community faces as well. So all of that together really, I think, shows the exact issue when you're talking about the disability community and the health disparities that exist.
Thank you. And just a reminder, while you are able to add questions to the Q&A section, we will be going over those questions at the end of the panel. That way, as you have questions, we will have a good set of questions at the end to ask our panelists. And thank you, Carl, for that answer. That's amazing. I'm always thrilled to see what kind of work all of y'all are doing, especially knowing how we are doing this nationwide. Our next question also, or does anybody else want to answer this question?
I can answer this question as
Really?
well.
Great.
So the community that I am here representing is the queer community, the LGBT community. I identify within that community, and I've also spent the greater part of like the last 5 years working on LGBTQ health, which is why I am in the field that I am. And so when it comes to disparities within queer health, unfortunately, we are more likely to be impacted by substance use, mental health issues. I'm sure folks here work in healthcare. People who are identified as trans are more likely to commit suicide, right? We're also greatly affected by chronic illness, more likely to be of low socioeconomic status, a lot of different things. So all of those things kind of toppled on with the way that identity politics affects our policy and access to healthcare, really do kind of lead to a lot of the disparities that we see in the LGBTQ population.
Thank you. And Shelby, I know you just popped in. I don't know if you're ready for this question as well.
Sure, I'll try and go pretty quickly. When we think about immigrants, people who are immigrants and their families, it's definitely not a monolithic kind of audience, right? So there are different kinds of barriers that people face in terms of accessing health, the health system and health services. And there's a lot of different disparities. And if we were to break up, the immigrants from different places and in different socioeconomic statuses and other things, we would see deep disparities and lots of different health disparities. But one thing in where I'm coming from today in terms of my participation in this panel is really focused on health coverage. And health coverage is actually getting access to health coverage. We know that people who are immigrants are less likely to have health insurance, and there's a variety of reasons for that. Some of that includes barriers to getting access to health insurance and the types of jobs that a lot of people who are immigrants are in, which is one of the main places where people get health coverage. Then traditionally, there has been a lot of bans of eligibility for some of the programs like Medicaid CHIP and even the ACA Marketplace that really creates like a wall against people being able to access different benefits that other people, if they met the same kind of circumstances as them, but they were citizens, they would be able to get, right? So there are eligibility restrictions. And then there's all sorts of kind of outreach type of issues. So even if somebody is eligible or their family members are eligible, oftentimes there's a lot of challenges for people to be aware, to trust. And I know that we're going to talk a little bit more about outreach. So just putting that out there, that in these buckets, there's a lot of different barriers that come up that result in a lot of people who are immigrants and their families being without health insurance.
Thank you. I think it's very insightful to know that while we serve communities, especially with healthcare, there are these barriers. There are differences when we talk about who's covered and what are the differences between the general population. So I think the next question would be, what cultural considerations do you all think we take into account when we're working with the communities that we serve? Like, why is cultural competency so important? And feel free to go the order that you were going, or I know y'all serve different populations, so feel free to answer as you like.
I mean, I would just say in general that, cultural competency is important, I think, for the trust and the relationships that can be built from that. When you are respectful and competent in the culture of whatever you're addressing, then you're able to to build those relationships and build that trust. And that's just, it's vitally important to be able to have that respect and that trust.
Yeah, and I would say also in terms of the issues related to cultural competency in the disability population, we talk lots of times about accessibility issues when it comes to the disability population, and most people think of those kind of things, making sure that things are accessible physically for people with mobility disabilities, or making sure that you've got ASL interpreters, or you've got things available in alternative formats for people that are blind. There's a lot of different things like that, but the bigger issue that many times goes unthought of by the general population when it comes to the disability population is attitudinal barriers. And some of the assumptions that are made. I'll use my own lived experience as an example. For those who don't know me, I use a power wheelchair for any sort of distance walking. I can stand and walk short distances, but with my disability, I am not able to walk any sort of length of a distance. And I always joke with people that when I'm in public and I'm in my wheelchair, unless it's in a professional environment, it seems like my IQ must go down by like 20 points by the way sometimes people interact with me. They immediately assume that because I'm in a wheelchair, it means I'm also have an intellectual disability, which obviously is completely not true. And so those are just some of the attitudinal barriers that we face in healthcare in general. For instance, I also, if I'm in my wheelchair, they assume I can't walk at all, which if I'm in a healthcare setting and a provider is trying to get a weight for me, I will many times remind them, hey, I can stand and get on a scale if you need me to, temporarily, as long as I don't have to be up there very long. But also reveals itself in other ways. Earlier, I mentioned, that women with disabilities are less likely to get Pap tests. That's because many times providers just assume, well, they're not sexually active if they have a disability, which is completely ridiculous. But because of that, many times the tests aren't prescribed for that reason. And it's just one of those things that the attitudinal barriers that exist with the disability population is one of the things that we really need to still move towards overcoming.
Thank you. I think second day of this panel, this is why we have these conversations, because we need these insights, right? Thank you so much for that.
Kind of along the lines of what the other folks here are saying as well, like to me, cultural competency is important because within even not just the population that I'm here talking about, but it's evident that within all of these populations, right, that kind of lack of cultural competency really creates mistrust, right? Like speaking on folks who are LGBT, and specifically, especially within like the trans community, right? Not having doctors who are competent enough to or engage with trans patients is so detrimental because it prevents folks from getting preventative care, right? And as we know, it's better to prevent than treat, right? As healthcare workers, and I have had so many experiences speaking to community where folks will say, like I literally just went in because my stomach was upset, or because I had a rash, or because of this, or because of that. But doctors feel like because they have a white coat, they are able to ask questions that are invasive and not necessarily pertinent to whatever care is being provided there, right? Questions around, surgeries, questions around like family dynamics, right? Things like that, like things that just aren't necessarily important to getting the care that patient needs, right? And I think especially like that lack of cultural competency just makes people not even want to go get help until it's like something that's a serious issue, right? Which I think is really unfortunate.
Yeah, this is, everything on this panel is super, super important to think about. When I think about immigrants and their families and some of the what's important to be thinking about in terms of cultural competency, I think something that can be done to help move in the direction of being mindful and thinking about how to do outreach and how to work with individuals who are immigrants and their families, and how to kind of bridge some of the gaps. I think there's such an important role that can be played by different groups, building partnerships with other groups that are well skilled and well placed within communities that have big groups of the folks that you're trying to reach, whether it's people from Ethiopia or people from El Salvador, or wherever. They're really taking the time to know like who's already serving the groups that you are trying to reach that are not represented already, that people haven't been able to reach, and identifying the trusted sources, people who have already built trust with them, and then really taking some time and understanding what is the best way to communicate around the opportunity to enroll in coverage, if that's your goal, right? And to help people enroll, and helping to the extent possible to identify opportunities to kind of enlist these trusted sources in your efforts to provide outreach. Oftentimes people think about cultural competence in terms of reaching people who are immigrants and their families, and they think language access, and that's important. It's very, very important. But I would say that's one step in a very complicated puzzle, right? It's really taking a moment of understanding, what does it really mean? Who are the immigrants that you're trying to reach? What are the different groups? Who do they trust? What are their language needs? Who can help us achieve our, high quality translations if we're trying to create translations? Where are the best interpreters, and what's the best language line to make sure that we're, it's fully inclusive in terms of our ability to communicate to people. So that you're really making an effort, really understanding what are the fears that the community has, or other barriers that they've experienced in accessing different benefits in the past, and really understanding the rules, because oftentimes people think, oh, well, a lot of people are blocked from being able to get coverage because of their immigration status, so we're just not going to worry about it. The reality is there are a lot of people who are immigrants that are eligible for different benefit programs, but it's complicated. So you have to really do the homework and the heavy lifting to find out who is eligible, so that you're ready to answer questions and address any concerns that people have as you're doing the outreach.
Thank you, Shelby. I think you're leading us to our next topic, which is policy and barriers. I know you touched this earlier, but I think one specific question I have for you is, especially when it comes to like the immigration community, how has the public charge impacted the immigrant community? And I know you just spoke, but I think like this just ties in great to what you were speaking on.
Thank you. So public charge, just to back up in case people don't know what public charge is, we have in our laws, our immigration law, there's for a lot of people who either want to change their immigration status within the country, or they're coming from outside of the country, but they want to come into the country and maybe become a lawful permanent resident or something like that. There's a test that they have to go through oftentimes. And this is oftentimes comes up for almost everybody who's coming in through some type of family unity pathway for immigration. So it's very relevant to a lot of people in our country. There's a test, it's called public charge. It's deeply embedded in our laws for more than 100 years, right? It's a law. And for a very, very, very long time, it was this test, basically an immigration official is trying to make sure that individuals who get this immigration status are not going to become fully dependent on the government for subsistence, or primarily dependent on the government for subsistence. So the way that it had been looked at in the past is when they're thinking about who is primarily dependent on the government for subsistence, they were looking at that, meaning they were getting cash assistance in the form of TANF, which very few people, I mean, not that few, but generally speaking, not a lot of people get this cash assistance within our country. The TANF program is relatively small when compared to like programs that are huge, like Medicaid. And or SSI, it's a bigger program, but there's a lot of eligibility restrictions that would keep a lot of immigrants away from being able to get it anyway, unfortunately, in many cases. And or some cash benefits that a state would have, like general assistance. And generally, these are programs that are quite small. And the other way would be for individuals who have the government paying for institutionalized care within like a nursing home that's paid for by the government. So like by Medicaid paying for like an individual who's in nursing home. So as you can see, these are programs that would impact a small group of people, a relatively small group of people, when we think about who's eligible for them and then who's likely to go through a public charge assessment. But under the last administration, there was a radical change in the definition of what it meant to be a public charge. And they brought into that definition use of Medicaid much more broadly, you know, which we know a lot of people get Medicaid, right? And the use of the Supplemental Nutrition Assistance Program, which is also known as SNAP, used to be known as the Food Stamps Program, and housing assistance. These are programs that are utilized by a lot of people in our country. So what ended up happening is a lot of people were like, whoa, that's terrifying. We just don't want to have anything to do with those programs because, you know, it's scary to us because it was confusing. There was a lot of misinformation about what the structure of that rule was. But what was clear to everyone under that rule was that there was a real intent to keep out from people's grasp, if they had low incomes, that it was going to be extremely difficult for them to achieve their immigration goals for a family. And as a result of that, what we've seen is a lot of people have been deterred from accessing benefit programs. They have been very fearful. There's been a lot of research that has looked into this, and people have pointed and said, whoa, we are worried about accessing these key programs like food assistance and Medicaid, even though they were fully eligible for these benefit programs, because they were worried that it might impact negatively on themselves or somebody in their families. There was just a lot of confusion and misinformation about that. And today we have a new public charge rule that really goes back. Well, right now we have a policy in place because this administration just did away with the old policy a while ago. So right now we have a policy in place that resembles much more what I just talked about earlier, right? This like limited to cash benefits and institutional care paid for by the government. And we do have a new rule. And that rule's not in effect until December 23rd, but nonetheless, for purposes of, you know, health coverage, Medicaid and stuff, that those things are in place today. You know, that aspect of it, there are some great enhancements that will come in that even further, should help us in our outreach efforts and helping people feel secure. But nonetheless, like for our purposes today, nobody should be concerned about accessing ACA marketplace coverage or Medicaid or CHIP Unless, I mean, you know, for Medicaid, we always have that little tiny thing, like unless you're in a nursing home and it's for long term, and even that's not decisive by itself, right? So, so in general, like when we're doing outreach to get people connected to Medicaid CHIP and marketplace coverage, we can tell people this is not the kind of services that would negatively impact you or anybody in your family later when you're trying to get an immigration status.
Thank you. That was very informative. I think the reality is we do this work, but there's when we served underrepresented or historically excluded communities, there's all these things that we don't know, right? It's like every application is different, but at the same time, there's so many things that they face because of these policy barriers. So I think that was very insightful, Shelby. Thank you so much. Sharon, I did want to ask you, how do we anticipate public health emergency Medicaid unwinding and impacting the community you serve? And if I said it too fast, let me know. I'm a little
No,
bit.
you did not say it too fast. I think probably one of the other panelists would be more suited to answer this, just because I'm not specifically in the healthcare arena.
Okay, no problem. Carl, would you like to?
Sure, I can talk about Medicaid unwinding because it is going to have a huge impact on the disability community. According to a report from HHS last year, it was over 37% of people with disabilities had coverage through Medicaid. It is by far the largest means of coverage for the disability community. So it is going to definitely have a huge impact on our community. We have already started laying some of the groundwork in terms of getting messages out, just as I know they were talking about earlier in the prior panel, about, you know, just making sure that people's contact information is up to date with state Medicaid agencies, and starting to, you know, lay the groundwork for when the public health emergency ends and the unwinding begins, that the disability community is ready to, you know, make sure that they are responding to the requests that are made of them by the state Medicaid agencies. So I think that's one of the things that we're going to be looking at, especially is because there's so many people with disabilities covered by Medicaid, does it have a disproportionate impact on our community?
Thank you. Thank you so much. I think these are very important points that need to be brought up, especially when we're talking about these communities. Angela, I wanted to ask you, I know you touched on the trans community. So can you describe any other discrimination experiences, or we could even touch back on the trans community that current policies or policies that they have faced?
Mm-hmm. So really, when we think about the shift that has been happening in policy over the last few years, and especially within like the last few months, actually, when it comes to various states and their attitudes towards LGBTQ identities. I mean, unfortunately, the trans population is really always under fire when it comes to these, right? Like we can even think about the recent legislation, I believe it was in Texas, right? Around like not around parents possibly being punished for providing or letting their trans kids access healthcare, right? And so that kind of just attitude kind of unfortunately has leaked into policy all over the United States. I live in California, and I will say luckily in California, people are pretty progressive thinking when it comes to trans identities, and thus there's a lot more protections there. But I do know that it is like definitely a struggle when it comes to other states, absolutely. And then just in general, like when it comes to these disparities, I think the biggest thing that we can think about as well is like, you know, I'll be honest, I do outreach work, so I'm by no means an expert in insurance. I would say for my, you know, for my age, I definitely have maybe more knowledge than the average 23-year-old regarding insurance, just because of the work that I do. One of the things that I will say, when I speak to community, especially the trans community, around insurance and coverage, is just that like things are so individual to different plans that like the hoops that you have to jump through to access care can really be daunting for folks. I mean, you're already dealing with, all of these different internal issues, right? Gender dysphoria, and you maybe have external stressors just from the world and living with, such a marginalized identity that also puts you at risk for violence a lot of the times, right? And then, even accessing care so that you can potentially get yourself in a place where you're not as susceptible to said violence, right? And then it's like hoops that you have to jump through, right? A few years ago, when I was in college, I actually did a research project that ended up being a publication around trans experiences in the Inland Empire seeking healthcare. And that was just really something that was shown even in California, right? Like insurance still, there's requirements that they're not allowed to deny coverage for certain, gender affirming care and things like that. But the reality is that insurance will pretty much find any reason not to pay out for these expensive, services, right? Whether it's HRT or gender affirming surgeries or pretty much anything, right? So it's something that really does create like disparities and barriers within that community.
Thank you. And again, yes, you might be young, but you're doing that work, and our lived experiences also are influencing these conversations. And I mean, I don't want to brag, but we are young led, right? So this is how we roll. So it's perfect. Sharon, can you describe discrimination experiences by the communities you serve? Because I know Angela is in California, so different. Like I know we have different policies, but I know in Texas, that's also a completely different world right now.
Yeah, the differences in policies between California and Texas are literally night and day. I will say one note to go back to the Medicaid unwinding. We know that is going to affect the poor working class folks, disproportionately. And for many of those folks, they live in rural communities, that I'm speaking for. And most notably, it's going to affect the states that have not elected to expand Medicaid. And Texas is one of those states. So, I think it's really important for, any navigators that are in Texas, you need to be aware of that, and aware that that's an option that our state legislature could choose to do. They have not, and it's something that, personally, off the clock, I talk to my representative about quite frequently, my state representative, because it's something that would affect so many people in a positive way, that it really is, it baffles the mind as to why Texas hasn't chosen, to do that. So I would encourage folks to, look at the policies of their states, and is the policy of your state, if they have chosen not to expand Medicaid coverage, then, that needs to be a policy area that we're speaking out on. And, if you aren't allowed to do that with the organization that you work for, you certainly can do that on your own time. And you can talk to your friends and your family, who can also reach out to their representatives and talk to them about it. Texas legislature only meets every other year, but we're coming up on a legislative year. So now's the time to be, talking about this issue. So I think I kind of veered a little bit there, but
no, it's perfect. It ties everything.
Yeah, because when it comes to policy, I mean, that's the biggest barrier that's facing Texans right now, and many of which are in rural areas.
Thank you. I think this is why we're doing this, right? We need those insights because we can talk about California, but we have those assisters in Texas as well. So this ties in to actually our next topic, which is strategies for assisters who may not work with the communities that you all serve. So I think I want to direct this to Carl, Angela, or Shelby. What are some tips for assisters who meet with a consumer from the communities you serve and may not feel as adequately informed about the specific needs?
Sure, and I'll also just take a step back too to talk just briefly about issues with discrimination and experienced by our community. First of all, point out that the Affordable Care Act is still worlds better than where we were, especially when it relates to the disability community and coverage for pre-existing conditions and all that kind of stuff. But there still is work to be done. It's still not perfect. And one of the things that we see that specifically in the disability community frankly, assisters really need to know when they're helping people select a plan is issues around things like network adequacy and making sure that specialists are within the network that the person's going to need. Many times people with disabilities have a specific specialist that they like, that they trust. And there's a lot of issues that we can talk about with providers and people with disabilities and how many times they don't understand disability issues. So when you find a provider that you really like and you really trust, you want to make sure that they're covered by your plan. So making sure that they're in the network. That also goes to mental health and network adequacy though. There's lots of times where you'll sign up for a plan and all the mental health providers that are covered by that plan, maybe they're not accepting new patients. And that can be a real problem. And then the final area of discrimination that I think it's really helpful for assisters to recognize is that we're still working, on trying to really fully realize what the ACA should mean for our community is around pharmacy design. And there is specifically, discriminatory pharmacy design that exists in health insurance plans. A common example I like to give is with people who have multiple sclerosis. Because of the medications they take, usually they are on the highest tiers when you're talking about copays and those kind of things. So if you're not familiar with how, pharmacy design tiers work, most people are familiar with the tier of a generic versus a name brand. And the fact that usually there's a different copay. Then there's also other tiers above that for specialty drugs, where the copays are even higher. And usually, say for instance, like I said, multiple sclerosis, the drugs that those people are taking usually are on those highest tiers. So they are paying the highest rates for copays and out-of-pocket costs and aren't fully getting the benefits of what the ACA really means. And that's one of the things that you're talking about, what we're trying to do to still, fully realize the ACA. That's one of the ways I think we can still do that. But that is something to be thinking about as you're helping people select plans, is looking at some of those more specific issues that are more specific to that person's situation, their condition, their disability, specialists they see, medications they take. And then also for people that have maybe mobility issues, it might be durable medical equipment that they need to make sure is covered. It's a lot of those kind of things that you're just thinking through those and making sure that what the person needs is really going to be covered by the plan that they select.
Thank you. You know what? That's on me. I should have asked you all these questions because I love that answer. And it touches on things that, again, this is why we're here today and it's insightful. So our next question would be, what are some resources for those assisters to learn more about working with, and Carl, can I do this with your community now that you told us all this?
Sure. And I mentioned earlier in my introduction that when I first started at AHD, it was to run what we refer to as the National Disability Navigator Resource Collaborative, which was a project that for the first 3 years of open enrollment was funded by the Robert Wood Johnson Foundation. We developed a lot of resources meant to help navigators. Most of that stuff is still timeless. Some of it might be a little dated, but a lot of that stuff still can be used in trying to think through some of the issues that affect people with disabilities. I'll put a link in the chat to the website we have for that. And then also specifically, I know sometimes we talk about, cultural competency and those kind of things we were talking about earlier. There's a fact sheet we specifically developed on disability etiquette that I'll put a link to that specific fact sheet as well in the chat, because that will be something I think that assisters may find useful as they're dealing with the community. And I'll just give you sort of the overall arching philosophy of when it comes to disability etiquette. Don't be afraid to ask the question if you're not sure. People with disabilities are used to people not necessarily understanding, the best way to serve them or deal with them and communicate with them. So asking the questions, there's nothing wrong with doing that. Most people with disabilities are more than happy to say what our preference is on certain things. So just ask the question. Don't be ashamed if you're not sure how to proceed.
Thank you. Shelby?
Yeah, I was just gonna say, a lot of folks may have already accessed the Protecting Immigrant Families Coalition's website. And if they haven't, I really recommend that you go onto the website. There's a lot of great materials that are already there, and they're constantly putting more materials out that can be a real great resource for people who are helping immigrants and their families understand who's eligible for benefit programs and who, really allay some of the fears around public charge. Also, I work for the Center on Budget and Policy Priorities, and we have an initiative called Health Reform Beyond the Basics. And we have a webinar that we do each year on immigrant eligibility, as well as goes over a lot of different application related issues and concerns. And we did a training last week or the week before with the National Immigration Law Center. And that's on our website on Health Reform Beyond the Basics. So I really recommend you utilize that as a resource. And always you can contact me if you ever have any questions.
Thank you. And we'll try to follow up with everyone and provide these resources, because one thing is talking about it. The next thing is that follow-up link, correct? So that's great. Okay, so my last question before we go into the Q&A, and this can be for anyone. What do you think is the most important or so important to provide more focused assistance for the communities you served? I know Carl already touched on that, and it was really insightful to know that we're able to ask those questions, and that actually opens up that platform. But what about for anybody else on the panel?
Angela, you want to take that?
I was gonna ask if she could actually repeat the question real quick, and
Yeah,
then
no problem. So what do you think it's so important to provide a more focused assistance to the community you serve for the sisters? I think this is something that could help them.
yeah. So for me, I think like more focus, at least when it comes to like the LGBT community, right, is like making sure that we are aware of like all of the needs, like the holistic needs of the community, right? Because I will say, like, at least when it comes to the LGBT community, I think it's fabulous, right, that we focus on like specific needs when it comes to like, trans care and their access to gender affirming services, or when it comes to other LGBT populations and like the special considerations that it takes when it comes to like sexual health care and things like that, right? But I also think it's important to remember that like the folks who come into your seats are also whole people and have whole needs, right? Meaning like just because they're trans, right, doesn't mean that they don't also possibly have or need other assistance, right? Especially like I think it's important to remember too that like all of the communities that we're talking about here today, none of them exist in a vacuum, right? Like they all exist in junction with each other. People hold multiple identities, and I think it's very important to like kind of remember that. And to just remember that like ultimately whatever the focus is going to be the focus of what that patient needs, right? And I think remembering that, because like just because someone comes in because they're trans, right, doesn't always mean that that's the care that they're focused on. Maybe they have a chronic illness, right? They're trans and they need access to care on that, but maybe their healthcare coverage or whatever it may be, right? Maybe they're more focused on what that means as someone living with a chronic illness. And I think sometimes, at least when it comes to like, you know, the LGBT community, people kind of get like blinders on identity, right? Which I think it's fabulous, right? Like take that into consideration, but also remember that some folks like just want to be seen for the people that they are, right? Versus like their identities that they hold. So yeah.
Thank you, Angela. No, that's great. I think this is one thing that will help those sisters, because there is a certain like process, but knowing the intersectionality of the communities y'all serve and knowing how it's not just one thing, but it could be different aspects of not just their identity, but other things that they're experiencing really gives us that insight. So thank you all today. Now let's go into the questions that we had from the community. And I think y'all touched a little bit on some of them, but I think there's one that has like a two-part. So I will be, hi Mina. I will be reading it. Okay. Could you talk, and I guess whoever wants to answer this question, could you talk about how to provide outreach and information to people with disabilities, especially people who are deaf and hard of hearing, especially as the public health emergency ends? How do we make sure they have access to notice and information in languages they understand and assess to sisters to help?
Yeah, I can take the first part of that, especially as it relates to the deaf and hard of hearing community. One thing that I always, take a step back. First of all, the Section 1557 is the provision within the ACA that talks about the civil rights section that really talks about, advancing and making sure that everyone and no one's discriminated against in healthcare settings. And it would include sisters as well under that, because it's anyone that receives any sort of funding as a result of the ACA, which the navigators and those do. And so as far as that is concerned, you are covered by that. And based on that, you should be providing those services to people if they need them. So if someone needs, for instance, a sign language interpreter, it's your responsibility to provide that and pay for that so that you can communicate with the person. Two things I would say about this. Number one is, if you're meeting with someone who is deaf or hard of hearing and you're trying to, help them enroll, ask them what their preferred method of communication is. You might find out it's not ASL. They may prefer to lip read or some other form. They may want to do it over the phone and use voice relay. So there's lots of different things that could be done to interact with that community. So I think it's important to ask that community, people from that community, specifically what their preferred method is. But I'd like to actually take it a step back. And if you run an assister program, I would encourage you that when you're hiring your assisters that are actually going to be interacting with individuals, that you think of ASL like any other language that you'd be hiring for bilingual folks. So that you think about it in terms of, if you're going to hire people that can also speak Spanish or you speak French or an Asian language, that you are also hiring people that know ASL, and that you look for that amongst your employees. Because if you can have someone on staff that's what they do, it's very easy then. You don't even have to worry about trying to set that up. So that's one thing I would make. That's one sort of, that's a best practice, I would say. It's obviously not a requirement, but it's maybe a best practice to be thinking about it in those ways. And then finally, the other thing in terms of materials to help reach the audience is just recognizing, excuse me, that just because if you're putting out a video, for instance, that has information, making sure it's captioned is important. But captioning only is going to reach so many people in the deaf community. There are some people in the deaf community that are illiterate and cannot read the captioning, in which case they need an ASL interpreter that's going to help with that. So thinking about building in ASL into some of your videos, especially if they are meant to reach a broad audience and are meant to, convey important messages, for instance, like around the Medicaid unwinding.
Thank you, Carl. You have all this great insight. Like, I love it. Okay, our next question is, how do we provide outreach and assistance to individuals with limited English proficiency, especially as a PhD ends? And this question goes to any of y'all.
I would say a couple things. One, I think it's not too soon to be in communication with your state to find out what their game plan is around the unwinding. There are a lot of states that have begun to be very assertive in terms of trying to track down folks to make sure that they have the best address and phone number, contact information, so that they can communicate with people, so that when the unwinding occurs, they are able to take action. There are also states are also underway in terms of developing different communications that are going to go out to consumers, right? So trying to make sure that your state, as they're developing those resources, including even the letters that are going out at, or letters or different communications that are going out to try to get up-to-date information, that all of that information is being done in different languages. I think that's important. States are also doing kind of more general outreach, and general is great, but you also want to have some targeted outreach, right? And in language outreach would be really, really helpful, because the concept is, the concern is that we've got 80 million people, right, around the country that are going to have to go through a renewal in 12 months, right? The time period roughly around 12 months. That's a lot. And people are going to need to know, and they're not going to need to hear it once, you're going to need to hear it multiple times. So one is getting a good understanding about what your state's game plan is and how they are envisioning language access, and making sure that they are taking the responsible steps that they must take as states that are responsible for meeting language access needs. So making sure that all the different communications are being done in different languages. And then, also trying to encourage them to do outreach in lots of different languages and different media outlets and all of the things. And then also, what are you doing, right? To the extent that you are engaging and trying to educate the community around the PHE unwinding, and that it's important for you to, contact the state if you've moved, and make sure that they have your best address, and making sure that, you take action and be on the lookout for different notices and stuff, and making sure that you are available, that you do all of those things, right? Like, you make sure that your communications are in multiple languages, that you make sure that you're able to answer, that you have a game plan in place to be able to meet all of the language needs that come to you. So that, as Carl mentioned, always great to have staff that can speak multiple languages, to the extent that there are languages, there's so many languages, right? You're not going to always have every single one of them in staff, but you have a game plan to be able to utilize a different language service to be able to, meet the needs of people. All of those things are great to be thinking about. And to the extent that you have the capacity to build, that you're able to work with in-language media, in different languages, and being able to say, hey, we thought you should know, and to do that kind of media outreach. A lot of people might be losing coverage, and it's important for your community to know about this. And here's the 3 things that we think are really important. Well, really working with, those different media outlets, and encouraging journalists to start writing about it, encouraging TV, radio, and all of the things to be putting information out, as well as social media.
Thank you, Shelby. That was great. And I'm trying to be mindful of our time. We are a minute over. Sorry about that. But that's what happens when we're talking about the intersectionality and barriers that underserved and historically excluded communities face. We go over time because these are important issues. I want to say thank you for everyone and our panelists here today for sharing your insights. I think this will help our sisters and everyone else that really wants to know how to have these conversations when they're doing the work. And we appreciate your time today. I would like to say thank you to everyone that stayed on for the extra 2 minutes. I think this is why we do this, and this is why we're going to keep that momentum and continue to serve these communities and everyone else with the great insights that were received here today. So thank you, everyone. And don't forget, you can still go into the lobby and have those chats.